question is about training nationals and how they're going to make their living, and is there any changes in that? What's going on?
You've been training nationals more recently than I have.
I think that's a question that's complicated to answer in a very short time, but at least in our experience at Kikuyu Hospital, I mentioned that we did lose a couple of really top surgeons that really disappointed us. But in the last few years, we've had better luck allowing them to do some private practice as part of within our own facility. And so allowing them to do some private practice at our facility where we at least had a little bit of control of their schedule, that did work better. I don't know how that's going to work in the long run. I think we'll still lose really good surgeons. Do you have a comment about that? We were using the standard all PMMA lenses made by Oralab. That was our standard lens, and we found creative ways to fit those into small pediatric eyes. We would put it into an eye that had a horizontal corneal diameter of at least 9 millimeters, but sometimes even we would fudge a little bit on that. And because the compressibility of the haptics, we could get it into the sulcus quite well in most eyes. We loved using Acrosoft lenses when they were available, but they were usually too expensive for us. I was afraid of using the Oralab foldable because it was hydrophilic, and when I saw reports of opacity of the optic in hydrophilic lenses, it frightened me away from using that. But I understand they're coming out with a hydrophobic lens. We didn't have any experience with that.
The first intraocular lenses that we used in children, which were actually we used in 1993, were hydrophilic lenses made by Alcon, a brand called Iogel. It's no longer made. But we didn't have any problems with them apart from late dislocation because there was very little fibrin and they didn't stick to anything that's so biocompatible. So they could pop out years later, which in some ways is an advantage because you could, in theory, correct the patient for emetropia in infancy, and then at the age of 6 or so, when growth of the eye is more or less stabilized, you take it out and put in a lower powered lens.
And yeah, we did have some 15-year follow-up on some of them, and they had done very well.
I didn't hear the question altogether, but
the question is, in contrast to the U.S., ophthalmology is not viewed as an attractive residency in East Africa. Could you comment on that?
I think we need to remember that even in the UK, up until about 30 years ago, ophthalmology was regarded as a so-called Cinderella specialty. It was quite hard to recruit people to it. And again, we need to put ophthalmology in East Africa into the context of a general lack of doctors. Tanzania has fewer doctors per head of population now than they did at independence. And so there is a lot of money to be made as an obstetrician gynecologist or a general surgeon. And ophthalmology doesn't attract that kind of reward. I think the other thing is that very often in the national teaching hospitals, the quality of ophthalmology teaching for undergraduates is not great. And again, I suspect there are parallels in the US, certainly in the UK. Ophthalmology for undergraduates is maybe 2 days in a 5-year degree program. And so they just don't get exposure to it. And I think we need to do much more about trying to arrange electives and things like that for students, medical students, to get interested in ophthalmology. And it's up to us as ophthalmologists to go into medical schools and try and sell our specialty. It's what I do in Glasgow, not because we need more ophthalmologists, but because I want the best students applying to ophthalmology, not the ones who can't get a job in anything else.
I would add, with the lack of a third-party billing system, the ophthalmologist is facing the prospect of buying very expensive equipment and trying to bill patients, and as was mentioned earlier, the patient's willingness to pay is much less in in that setting.